Okay, so this lecture is about to using the electronic apex locator in the endodontic practice. What are these electronic apex locators are? These are those devices which are used to determine the working length of a root canal without the help of a radiograph. EALs, or the electronic apex locator, these are considered the most optimal and accurate method to establish the root canal working length at present. Electronic apex locator, they are used to locate the apical constriction or cemento-dentinal junction, apical foramen, but they do not able to determine the radiographic apex. That is why we use the term electronic root canal length measurement device instead of apex locator. If we look at the morphology of the endodontic system, we can see the major foramen. This is the major foramen. Then we can see the minor foramen, where the dentin and the cementum, as well as the pulp is getting constricted. So this is the minor foramen. Well, this is the cementum, this is the dentin, and this is the root apex or the radiographic apex of the root. In clinical practice, the minor apical foramen or apical constriction is a more concise or more consistent anatomical feature and is the preferred landmark for the apical endpoint for root canal treatment. The apical foramen is not always located at the anatomical apex of the tooth. The foramen of the root canal may be located at one side of the anatomical apex. Sometimes it is up to 2 millimeters short of the radiographic apex in almost 50% of the roots. And the reason is secondary cementum deposition. And why it occurs? Because of the occlusal wear and tear, which we call the physiological attrition as the age advances. If we look at the radiographic method of canal length determination, it has certain limitations. Radiographic determination of working length has been used for many years. The radiographic apex is defined as the anatomical end of the root as seen on the radiograph, while the apical foramen is the region where the canal leaves the root surface next to the periodontal ligament. When the apical foramen exits to the side of the root or in a buccal or lingual direction, it becomes difficult to view on the radiograph. Well, dense bone and anatomical structures can make the visualization of root canal files impossible by obscuring the apex. And at times what happens, the zygomatic arch, it also obliterates the view of the apex, especially if correct angulation is not used in the paralleling technique or the X-ray is taken in the bisecting angle technique. The deposition of the secondary dentine and cementum can move the apical constriction further away from the accepted limits, causing the preparation errors, which I have already mentioned. A radiograph provides a two-dimensional image of a three-dimensional structure and is technique sensitive in both its exposure and interpretation. Some authors recommended to make adjustments required to working length using the radiographic method. About 68% of the examiners agreed adjustments up to 0.5 millimeter are required. Well, no matter you are going for the radiographic method or you are going for determination of the length using the electronic device, a preoperative radiograph is always essential for successful endodontics to determine the anatomy of the root canal system, the number and curvature of the roots, the presence or absence of pulpal pathology, etc., etc. The electronic apex locator, if used with appropriate radiographs, it gives much greater accuracy of working length control. The use of apex locators has various advantages over the conventional methods of working length determination and locating the apical constriction. Let's see how this system it has been developed over years and years. The first generation apex locators, they were introduced in 1969 and they were using the resistance method and the alternating current. Second generation, the change in frequency method of measuring was developed by, I know, in 1971 as the Sono Explorer Hayashi Dental Supply, Tokyo, Japan. Third generation apex locators are similar to the second generation except that they use multiple frequencies to determine the distance from the end of the canal. The index, APIT index are reported in the literature which give a combined accuracy of almost 81% to within plus minus 0.5 millimeter of the apical foramen. And that is reported by Tora bin Nijad, who is a good author who has written a book on the endodontics, and currently he is head of the Department of Endodontics in Loma Linda University. Then root ZX has the accuracy of almost 95 to 99%. The fourth generation Bingo 1020 or RayPix 4, they were introduced. Tinas et al. In 2002 found the Bingo 1020 to be the accurate as the root ZX in an in vitro study and easier for a beginner to use. This unit has subsequently been marketed by Dentsply by the name of RayPix 4. The fifth generation of apex locator devices were developed in 2003. They measured the resistance and capacitance of the circuit separately, and the addition of a diagnostic table including statistics of values at different positions made it easier to diagnose the position of the file. Woodpeck's 5A is highly efficient apex locator that aids the dentist in accurately determining the working length to carry out endodontic treatment. The sixth generation of adaptive apex locators overcome the disadvantages of the fourth and fifth generation of the apex locators, which have displayed low accuracy when working with wet and dry canals respectively. So the advantage of the sixth generation of apex locator is that they continuously define the humidity of the canal and adapt to the dry or wet canal. So this makes it possible for it to be used in dry and wetted canals as well. Moreover, their usage can be extended to canals with blood or exudates and canals in which the pulp has not been extirpated. Impedance-based devices, which we are using now. Newer apex locators are alternating current of 2 frequencies. They use that. These impedance-based devices measure and compare 2 electrical impedances that change as the file moves apically. Unlike older direct current-based locators, impedance-based ones are less affected by the conductive fluids like blood or irrigant in the canal, and they give very good accuracy. If we look at the components of these electronic apex locators, lip clip, then the file clip, this is known as touch probe, then the measuring cable, then the this electronic device, and the rechargeable battery. Mechanism of action of the apex locator. Root canals of teeth are surrounded by dentin and cementum. These tissues are insulators to the electric current. At the apical foramen, there is a small hole in which conductive materials within the canal are electrically connected to the periodontal ligament, which is a conductor of the electric current. The resistive material of the canal, that is dentin or tissue fluid with a particular resistivity, forms a resistor, the value of which depends on the length, cross-sectional area, and the resistivity of the materials. If an endodontic file penetrates inside the canal and approaches the canal terminus, the resistance between the end of the instrument and the apical portion of the canal decreases. Because the effective length of the resistive material inside the canal, it also decreases. Apex locators, they use the human body to complete that electric circuit. One side of the circuitry is connected to an endodontic instrument and the other end to the patient's body, either patient's lip or maybe patient is holding an electrode in their hand. So whatever you use. The impedance between the lip and the periodontal ligament is known value, which is 6.5 kilo ohm. When the file tip is advancing towards the periodontal ligament, the electronic apex locator device, it detects the change in the impedance values and indicates that the apex is approached on its screen. So here we can see as we are advancing, and it will be showing the reading, and once it is reached to the apex, it will give the reading. Just it is a schematic diagram. Well, on the screen of these new apex locators, you will be seeing these icons, the setting icon, then the sound icon, then the measuring cable connector and the lip clip or file clip symbols, and the full canal image, as well as the apical zoom image. When you switch on the device, you press on the on-off switch to switch the device on. After welcome melody and welcome screen, the main screen is displayed like this. This red means that the measurement cable is not yet connected. Connecting the measurement cable to the device. Make sure that the measurement cable is not yet connected to the patient before you will connecting it to the device. Firstly, attach to the device, then take it to the patient. Plug the measurement cable into the receptacle of the electronic apex locator. The connector symbol will turn from red to gray, this one, and the two electrode symbols, they will turn yellow. It means an open measurement circuit. Means the current is there, but the circuit is not yet complete. Cable connection test. Connect the file clip contact to the lip clip. The connector symbol and the lip clip file clip symbols will turn green, means that the current is now flowing. Your connections are correct. And even if you have any doubts while you are working, you can do it again and again as well in order to be sure that your connections are good. Starting length determination. Connect the file clip and the lip clip to the measurement cable. Before connecting the measurement cable with attached lip clip and file clip to the patient, make sure that the measurement cable is plugged into the device receptacle before attaching it to the patient. Place the lip clip on the patient's lip on the opposite side of the tooth to be treated. Like say, for instance, we are treating this tooth, so the lip clip will be placed on the opposite side. And that's how directly to the metal, the file clip is going to be attached. If you are working in a distant molar and you are having some difficulty, you can use this touch probe for that purpose. So this file clip is going to be attached to that, and this fork type thing, it is going to be attached to the file. So for the molars, you can use this. This is an optional instrument. Beginning of the length determination. Two initial beeps indicate closed measurement circuit and beginning of the length determination. Once you will enter, there you will hear two beeps. The file movement in the canal will be shown here as well as shown here. And this elliptical blue, it will show that you are now in the canal. Absence of the two initial beeps and no progress of the file indicates faulty connection. Check the connection. Disconnect the measurement cable from the patient. Check proper connection between the measurement cable and the accessories. Clean the file clip, touch probe contact, irrigate the canal if required. And yes, remember, don't let the irrigant too much inside the canal. Dab using a cotton ball or maybe a paper point, so that there will be very minimal amount of the irrigant, if at all, left in the canal. Coronal and medial section of the canal. Slowly insert the measuring file into the canal. File movement along the coronal and medial sections towards the apical region will be shown on the full canal image. This is the full canal image by the ellipse continuously moving down from here to here. It will be shown when you will be reaching the apical area. It's not yet visible over here. Apical section. Zoomed view, this is called the zoomed view, of the file progression will be shown on the enlarged image of the apical part of the canal, which we call apical zoom, as you will be reaching close to the apex. In the apical section of the indication line indicates the exact position and changes accordingly from blue to green and then to yellow as you will be approaching close to the apical foramen. Important points as you progress apically. The apical indication line shows the file tip position inside the canal. Blue section, warning zone very close to the apical region, this area. Green to yellow sections, apical region is there now. And red bar, you are at the apical foramen. When the file tip reaches the apical foramen, the indication line is marked red and a constant sound is going to be emitted. Constant beep will be heard. In case of over-instrumentation, what happens? Once the file tip, it crosses the apical foramen and enters the periradicular region, the warning red dot appears beneath the apical zoom image and short warning beeps will be heard. Completion of measurement. Once you are done, you know that you are still in the blue region, that is your working length. You adjust this rubber stop. So before unplugging the measurement cable from the device receptacle, disconnect the lip clip and the file clip from the patient. Firstly, disconnect from the patient. Move the file stopper, this one, to the selected reference point on the tooth. Gently remove the file from the canal and measure the apical length between the stopper and the file tip. Certain important considerations. If it is too fast movement or even you are, right, it's giving you that indication you are at the apex, what could be the reasons? Excess liquid in the pulp chamber or root canal, rinsing solution like the irrigation solution, blood or saliva, creating wrong conductive path and incorrect measurements. Solution, dry the excess cavity with a cotton pallet, air blower, wait until excess bleeding can be stopped. You can use even the paper points. At times, what happens if there is open pulpiters, the gingivae, they proliferate and they enter, which we call the open pulpiters or which we call the chronic proliferative pulpiters. So gingival proliferation occurs, can lead to direct or pulp polyp, which we also call, can lead to direct contact with the measurement file, causing a short circuit and incorrect measurement. So isolate the excess cavity by adequate preparation, filling, placing a rubber dam or electrocauterizing of the soft tissue in that area. The measuring file contacting metallic restorations, crown or parapulpal post, amalgam filling may cause a short circuiting and incorrect measurements. Carefully enlarge the excess cavity and isolate with flow composite. Like say for instance, there is the canal and there is amalgam filling over here, which could be giving you trouble. Since some of the amalgam is left. So what you can do, you can use flowable composite to isolate this area so that it will work as an insulator and you will be able to continue your work. So carefully enlarge the excess cavity and isolate with flow composite. Widen carefully the opening at the top of the crown. Well, at times it is taking quite long time. It is not giving you any indication that maybe your file is stuck somewhere. It is not showing you any progress. So what could be the reasons? Obliterated root canals. It could be obliteration over there, impeding the conductive path and preventing normal device functioning. Check the comparative X-ray, which you have taken earlier. catheterize the ISO, a small file like size 6 or size 8 file, till the working length. You can use even at times EDTA for that purpose to make the canal more patent using the smaller size files. Retreatment may cause blockage as well. So blockage would be by old canal filling material, residue impeding the conductive path and preventing normal device functioning. It could be gutta perca, or it could be some cement over there, or root canal filler, whatever. So take an X-ray to recheck and try to completely remove the old canal filling material prior to measuring. Blockage by the remnants of a medicated substance, for example, calcium hydroxide. At times we place the calcium hydroxide in case there is a weeping canal, or if there is like open apex, especially in the immature permanent teeth. So that calcium hydroxide, it could be impeding the conductive path and preventing the normal device functioning. Completely remove the remnants prior to measuring. Extremely dry root can also be a problem. Extremely dry root canal, it impeding the conductive path and preventing the normal device functioning. Rinse root canal with irrigating solution like either the normal saline or sodium hypochlorite, and try the excess cavity with the cotton pallet and the air blower, and then proceed with the procedure. Comparing the length determined by the electronic method using the radiographic length. Dental x-rays, they show two-dimensional projection of the three-dimensional root canal system. They can ask you this question that using the radiographic method, it was a different length, but when we determined it using the electronic device, it was 0.2 millimeter or 0.3 millimeter, less or more, whatever. So that is why in some cases the radiographic length and the electronic length, they do not match. In the case of a lateral canal curvature, the X-ray may show a shorter working length as compared to you have measured using the electronic device. Electronic length determined using an EAL is usually more accurate than the radiographic length. Nowadays, the best method is using EAL and relying on it. But before you proceed to use it, it is always advisable to practice, practice, and practice. Contraindications. Always check the user's manual of the device before using it, and should have a complete medical history of the patient on whom you are intending to use the EAL, because some of the manufacturers, they clearly state that it is contraindicated to be used on the patients having implanted electronic devices such as pacemakers, etc., etc. And one example is Rapex 6. Though it is the latest one, but still they say that it should not be used on those patients who have the pacemaker. So if they ask you a question in your exam that whether it is contraindicated or it is indicated, always tell them it depends upon the manufacturer to manufacturer, and it is always advisable to look at the user's manual. If there is still any doubt or it is not mentioned in the user's manual, better to contact the manufacturer before you start working on any of the products. Well, I have used all these references over here: Grossman, then textbook of Endodontics, evaluation of the use of 6th generation apex locators as a diagnostic tool to detect root perforations by these 3 authors, then the operating manual of the latest apex locator, electronic apex locator, that is Rapex 6. So thank you very much, and soon I will be back to you with 2 more lectures on different things like AED and the pulp tester, and we will inshallah discuss those as well soon.